Think Forward. Think Research Channel.
So the outline of our talk tonight, I will talk to you about the definition of stroke, stroke risk factors, and women-specific stroke risk factors. And Dr. Kumar will speak on the acute management of stroke and the Stanford Stroke Center. So first of all, what is a stroke? Stroke is a brain injury caused by a sudden disruption of blood flow to the brain. It may be due to a blocked artery, and as you can see here on the right, there's a blood vessel here, and there's interruption of blood flow due to a clot, and this sort of purple brownish area is representing the injury to the brain due to the lack of nutrients going to the brain. A stroke can also be due to a rupture of an artery, and we call this hemorrhagic stroke, or it's a bleeding type of stroke into the brain. So what are the percentage types of ischemic and hemorrhagic strokes? Ischemic stroke, or stroke due to the blocked blood vessel, certainly takes the pie here at 88% and is the most common type of stroke. To a smaller degree, it may be due to intracerebral hemorrhage, or that's blood in the brain tissue, or due to a condition called subarachnoid hemorrhage, and that's where you have blood that surrounds the brain. This is an example of an ischemic stroke. On the left here, you can see the artery coming up. This is called the carotid artery, and it branches nicely here. And on the right, there you can see a cutoff here due to a clot in the vessel. And this is a cerebral angiogram. It's a special procedure that we can do to put a catheter up and inject dye to look at the blood vessels in the brain. This is an example of a brain hemorrhage. On the left here is a CT scan, which is an X-ray of the brain. And in the center here, you can see this bright area here. That is a hemorrhage. On the right is a pathological specimen of a brain with blood in the brain. This is an example of a subarachnoid hemorrhage, which not uncommonly is caused by outpouchings of the arteries in the brain. And then here on the left, you can see this sort of rupture. It may not come clear to you in the back. And it results in getting blood that surrounds the brain. This is a pathological specimen of a brain. So now let's focus on some startling stroke statistics. Each year, about 700,000 people experience a new or recurrent stroke. Approximately 1 in 4 people die within 1 year of having an initial stroke. And stroke is the third leading cause of death in the United States, following heart disease and cancer. These are the leading causes of death for all males. This includes all ages and all ethnic groups, and this is death in thousands. And this the red area is due to heart attacks, heart failure, and strokes. And you can see that is the leading cause of death in males, followed by this blue bar, which is from cancer. And then this tan area is due to accidents, such as motor vehicle collisions. And in contrast, these are the leading causes of death for all females. Again, to point out, this red bar is the highest, and this is due to cardiovascular disease and strokes, followed by cancer in the blue, and then due to chronic lower respiratory diseases in the yellow. I put this slide on just to, again, bring home the importance of stroke. This is age-adjusted death rates for coronary heart disease, stroke, lung and breast cancer for white and black females. And you can see here among white and black females, it's approximately twice that in stroke compared to breast cancer. So twice as many women die of strokes than breast cancer. And this is a slide showing the estimated direct and indirect costs of major cardiovascular disease and stroke. And stroke is approximately $63 billion. The direct costs refer to the actual care of the patient, medications, hospitalization, rehabilitation, and the indirect costs refer to the lost wages of that individual. So now we're going to turn to some common causes of ischemic stroke, since ischemic stroke is the most common type of stroke. And this may be due to narrowing of the blood vessels in the brain or in the neck. And what can happen is you can get a clot that forms or a thrombosis and have decreased blood flow up into the brain. Or sometimes, as you can see here on the left, this atherosclerosis, you've probably heard of plaque buildup, can not only cause narrowing and decreased blood flow, but little bits of that plaque and clots can form and break up and go into the brain. Similarly, clots can form in the heart due to various medical conditions such as atrial fibrillation, which is an irregular heart rhythm, valvular disease, or recently after a heart attack when the heart isn't pumping as well. And these can form clots and break up, what we call an embolism, up into the brain. And this is actually, I put the yellow arrow in, this may be probably one of the top causes in women in regards to strokes. So how can we prevent a stroke? We need to take a closer look at stroke risk factors. And there are certain non-modifiable risk factors such as age, gender, and race. Obviously, we can't slow down the clock. And then we have modifiable risk factors due to medical conditions such as high blood pressure or hypertension, and then behaviors or habits related to smoking or things like that. So in regards to age, the risk of stroke increases with increasing age. The Framingham study was a study done in the northeastern part of the United States many years ago, and they noted increasing incidence rates per 10,000 people, starting from in your age from mid-50s to mid-60s. When you jump from mid-60s to mid-70s, this practically doubled. Just an example of, unfortunately, age increases our risk of stroke. So to focus on gender, men actually have a higher incidence of stroke overall compared to women. There are exceptions. Exceptions are age-specific groups in women ages 35 to 44 and after age 85, in which women have a higher incidence. And this, the younger age group, 35 to 44, may reflect pregnancy, women of childbearing age, birth control pills, things like that, that I will go into more in detail later. And then it's thought that the older age group, women tend to live longer than men, and that's why they think there may be a higher incidence in that sort of older age category. And in 2002, 62% of U.S. stroke deaths were actually women. Also in regards to gender, women have more severe strokes than men. Women have worse functional outcomes at discharge from the hospital and at 3-month follow-up evaluations. And women have lower quality of life scores compared to men on follow-up. These differences are not entirely explained by age alone, and further studies need to be done to help explain this. In regards to race, blacks and Hispanics have a higher incidence of stroke compared to whites. The atherosclerosis risk and community study in the late 1980s, this was a study done in the southeastern portion of the United States, found that blacks had a 38% higher incidence of stroke than whites. And possible explanations are that blacks have a higher prevalence of hypertension and diabetes than whites. In regards to medical conditions that are stroke risk factors, hypertension or high blood pressure, heart disease, an irregular heart rhythm or atrial fibrillation, high cholesterol, diabetes, carotid stenosis or narrowing, and prior stroke or transient ischemic attack are risk factors. Transient ischemic attack also is referred to as TIA or mini stroke, and these are typically symptoms that last less than 24 hours, but it's an important thing to recognize because this actually may be a prelude to something more severe like a complete stroke. And these yellow arrows point to women-specific sort of risk factors in regards to medical conditions that are associated with causing strokes in women. So I put this slide in. It's a busy slide, but the point of the slide is that on section A, you have no risk factors, and section F is where you have multiple risk factors. And as you can see in both men, which is the red, and women, which is the purple, your risk of stroke increases with increasing risk factors. And this is an estimated 10-year risk in a 55-year-old adult according to the level of various risk factors, with, again, F having the highest number of risk factors. So what about blood pressure? What we do know is the lower your blood pressure is, the lower the risk of stroke is. This was a study done in 2000 and was published in 2001, and they looked at patients who had sort of high normal blood pressure or borderline blood pressure. And they can, as you can see here in this yellow line, compared to the other individuals who had lower blood pressures, they had higher cardiovascular events. And in this study, this was cardiovascular events were heart attacks, death due to cardiovascular disease or stroke. So again, even if you have borderline high blood pressure, it's very important that you treat that and get it under control. In fact, blood pressure lowering reduces your stroke risk by about 30 to 40%. Blood sugar control is recommended for prevention of stroke and cardiovascular disease. And cholesterol lowering reduces your stroke risk by about 20 to 30%. And your target LDL, that's the bad cholesterol, should be approximately 100. And the HDL, your good cholesterol, should be above 35. So what about behaviors? Smoking. Smoking is a horrible risk factor for stroke, so we recommend that you quit. Studies show that the risk of stroke decreases after quitting, and the elevated risk disappears after 5 years of smoking cessation. And even Van Gogh knew that smoking was bad for you. And I think this highway sign or billboard sums it up nicely. If you really need to taste tar, lick a highway, it's safer. What about alcohol consumption? Is alcohol beneficial for stroke prevention? Or, what we found in studies is that actually if you do drink a couple of drinks a night, such as a glass of wine or two, that this actually may have some protection in regards to stroke. However, if you're drinking more than 5 glasses a night, your risk of stroke goes up exponentially. This is not an advertisement to start drinking. This is merely to say that if you do drink a glass of wine with dinner, that's all right. How about physical inactivity? Studies have shown that moderately active men or women had a 20% lower risk of stroke, and the American Heart Association and American Stroke Association guidelines recommend 30 minutes a day of moderate exercise for healthy adults. And this seems like a daunting task in such a busy society today, but if you can get in 30 minutes a day walking, that would be great. I should say that moderate exercise is defined by at least 3 miles per hour, say walk on a treadmill or outside. This also includes swimming or biking, things. So now I'll focus on some women-specific stroke risk factors: birth control pills, hormone replacement therapy, pregnancy, and women with migraines. So in regards to birth control pills have changed a lot over the last 40 years. In the 1960s and 1970s, they used very high doses of estrogen, and estrogen is associated with clotting. And now the concentration is much different in this day and age, and so it's thought that overall birth control pills are safe to use. However, women smokers who use birth control pills have a higher risk of stroke than non-smokers who use them. And the risk is greater if you already have other risk factors such as high blood pressure, high cholesterol, or if you're over the age of 35. And women who use or are considering using birth control pills should discuss the possible benefits as well as risks with their physicians. In regards to hormone replacement therapy, studies have shown that hormone replacement therapy increases the risk of stroke. Currently, the Federal Drug Administration, or FDA, recommends that hormone therapy be used at its lowest doses for the shortest duration needed to achieve treatment goals. And hormone replacement therapy should be used only if the menopausal symptoms are severe. These recommendations stem from a study called the Women's Health Initiative that was done in the 1990s. It took a large population of women, and they were randomized to receive estrogen and progesterone tablets or a placebo tablet. The study was actually stopped prematurely because they found an increased rates of breast cancer. But when they looked back in regards to following these women over 6 years and looked at their stroke rates, they found that after about 2 years, the hormone group actually had higher rates of stroke. And so that's where those FDA guidelines are stemming from. They also looked at a subset of women and looking at the effects of estrogen on postmenopausal women with prior hysterectomy. And they also found that those receiving estrogen or hormone had higher rates of stroke. Some women-specific stroke risk factors, again, are pregnancy. The risk of stroke is higher in women during pregnancy, delivery, and the first 6 weeks following childbirth. It is important during your pregnancy to have your blood pressure checked as well as monitor any other risk factors such as diabetes. And this is a study looking at the risk of stroke in women in the 3rd trimester, peri and postpartum period, and comparing them to the risk of stroke in non-pregnant women and women in the first 2 trimesters. And you can see in the center here, this is around the time of delivery. The red is due to ischemic stroke or the blocked blood vessel. The purple is the hemorrhage into the brain, and the yellow is the subarachnoid hemorrhage. And it's actually around the time of delivery that this risk goes up. Again, this is compared to non-pregnant women. And in general, overall, that age category has a low risk. But they have a relative risk increase. And this also is increased in the postpartum period. I also included migraine in this presentation because many women suffer from migraines. And what we know is migraine without aura. Aura refers to sometimes people get numbness or weakness or visual changes with their headaches. And migraine without aura actually was not associated with increased risk of strokes. But migraine with aura is associated with higher risk of ischemic strokes. The absolute stroke risk increase in migraineurs with aura is approximately 4 per year per 10,000 women. And overall, this is a lower risk, but overall the risk is low, but it is a risk nonetheless. So what are stroke symptoms? And if there's anything that you come away from this presentation, this is something to focus in on. The brain is an interesting organ. Actually, the left side of your brain controls the right side of your body, and vice versa. The right controls the left side. And then you can see in this figure here, there's a stroke going on the left side, and this stick figure patient has weakness on his right face, arm, and leg. So symptoms include difficulty talking or understanding words, loss of feeling or strange sensations on one side of the body, weakness on one side of the body or face, a severe unexplained headache, sudden decreased dim or blurred vision, and unexplained dizziness or loss of balance. And I was talking to my parents about, they had read on the internet about how to evaluate if you're suspicious that someone's having a stroke at home. And I guess there is 3 simple steps that you can do, which I thought seemed very reasonable. You can ask the person to say their name or try to talk to you. And you can ask them to show you their teeth or give a smile. And the third thing you can do is ask them just to hold up their arms and see if they're able to lift it up. So those are some 3 simple steps that you can do if you're at home and you're suspicious that someone's having a stroke. So why should you know stroke symptoms? Stroke patients have the best chance if someone recognizes their symptoms early and acts quickly. Know the symptoms and save your own life or the life of someone you know. Time is brain. A stroke is a medical emergency. If you suspect a stroke, call 911. Thank you.
Good evening. For the second half of the talk, we will focus on stroke treatment in the acute setting. We will explore the role of brain imaging, different medications, different strategies like brain protection, and we'll talk about what's on the horizon for stroke treatment at the Stanford Stroke Center. But before we can talk about the treatment of stroke, I want to revisit what a stroke is. So if you recall from Dr. Finley's part of the talk, when a blood vessel is occluded by a blood clot, it prevents passage of blood, oxygen, and nutrients to the brain. The part of the brain that's irreversibly damaged is called the core of the infarct, and the part of the brain that's salvageable is called the penumbra. This here is represented by the core, and this kind of hazier white is the penumbra. So it follows that if strokes are caused by blood clots, then stroke treatment should be aimed at removing the clot. Enter TPA, the clot buster. Many of you may be familiar with TPA. It's the only FDA-approved medicine for the treatment of acute stroke. And what you see here, this is another angiogram, and this is a blood vessel. And here you can see that the contrast in the blood vessel stops. And that's because there's a clot there that's occluding the flow of contrast. After TPA, you see that there's resumption of flow. So who's eligible for TPA? Well, first, you have to have symptoms suspicious for stroke. You have to have the onset of your symptoms within 3 hours. And you have to have a CAT scan that shows no evidence of bleeding. As you may have guessed, the side effect of a clot buster may be bleeding. So if you've had recent head trauma or major surgery or any bleeding from other parts of the body or bleeding in your brain from before, well, all of those reasons that you might not be a great candidate for getting TPA. If your blood pressure is too high when you present, then that might be another risk factor for bleeding into the brain. If any of you are diabetic in the audience, you might know that if your blood sugar is too high or too low, you may have something that looks and seems like a stroke, but really it's just a mimic, and so that's another exclusion for TPA. So who doesn't get TPA? Well, if your symptoms are getting better, then maybe the risk-benefit ratio is a little bit offset, and maybe we'd watch you before we give you the TPA. Like we said, some people who have blood pressure that's too high, they might not get it. If you have other medical reasons like a brain tumor or something like that, you also might not be eligible. But I didn't really put this slide up here to tell you who shouldn't get TPA. The reason I put this slide up here is because I wanted you to see that the majority of patients who don't get TPA don't get it because they don't come to the hospital fast enough or don't realize that they're having a stroke and so don't seek medical attention. So what can we do to offer more patients acute medical treatment? Enter the Stanford Stroke Center. Broadly, the goals of care at the Stanford Stroke Center is to provide the best stroke treatment to patients that's possible. What we'd really like to do is to expand the time window and investigate novel approaches to acute stroke therapy so we can better treat patients with acute stroke. Specifically, we'd like to explore the role of neuroimaging with MRIs and CAT scans to identify patients who can benefit from treatment maybe beyond 3 hours. We'd like to determine the optimal use of intra-arterial therapies, and we'll touch on them in a little bit. And we'd like to identify novel treatments for brain protection and recovery from their stroke. So all of you, I'm very sure, are aware of who Dr. Albers is. And in an attempt to do just this, but to offer acute stroke therapy to more patients, Dr. Albers, the director and founder of the Stanford Stroke Center, set out to determine whether or not MRI could help identify patients who were at higher ability of getting TPA outside the 3-hour window. And I hope that I can do him justice in presenting this to you. Basically, a patient comes to the emergency room outside the TPA window with what looks like a pretty sizable stroke. You do an MRI, and you see that the core of that infarct is still pretty small, even though the penumbra, or the tissue at risk, looks pretty large. And that's because there's a clot that's preventing blood flow. If you are able with TPA to open that artery, you see that the tissue at risk is resolved and the stroke stays small. This is the favorable profile. However, a similar patient could look identical in the emergency room. But if the MRI shows that the core of the infarct is already large and the tissue at risk is even larger from that same clot, if you open it up, you could end up resulting in a large stroke. So the main limitation of TPA is the risk of bleeding. Is there a safer version of TPA that you could administer over a longer time window? Enter the South American vampire bat, Desmodus rotundus. The saliva from this bat contains a TPA-like substance that's more specific for clot and so results in less bleeding. The Diaz trial, or desmodoplace in acute stroke trial, showed that in an appropriate subgroup of patients, in contrast to TPA, patients who were treated early or late did just as well. With TPA, the sooner you receive treatment, the better you do. With desmodoplace, those patients who came in between 3 and 6 hours did just as well as those patients between 6 and 9 hours. What was even better was that even at 5 hours, which is 2 hours beyond the TPA window, there was no increased risk of bleeding in the brain. So far, we've been talking about intravenous treatment of stroke, and that's giving a medicine that goes all throughout the body to really treat the blood clot that's in the brain. So is it possible to treat that clot directly? So there's been some studies that have shown that up to 6 hours, you can take a catheter through the groin, snake it up to the site of the clot, and deliver a smaller amount of TPA directly to the clot. And you can see that depicted in this cartoon. This is a blood vessel with the catheter, the blue thing, coming up through it. And this is the clot, and it's delivering TPA right at the site of the clot. So are there alternatives to dissolving the clot? Is it possible to maybe just remove the clot? Enter the Mercy device. Dr. Michael Marks, another member of the Stanford Stroke Center, was integral in bringing this technology forward. And basically, what the Mercy clot retrieval catheter is, this is another angiogram without the blood vessel that's visible. These arrows demarcate the catheter that's coming up, and this is a corkscrew. So basically, you deploy this corkscrew, it ensnares the clot, and then it sucks it back into the catheter, removing the clot from the system. This is a picture of one of the clots, 15 centimeters long. It's pretty amazing. What's more amazing is that you might have seen the TV debut of the Mercy Clot Retriever on ER once when Cynthia Nixon, who plays Miranda Hobbs on Sex and the City, came in with an acute stroke where she was mute and couldn't move her right side. Even though the Mercy device is the only FDA-approved device for acute stroke therapy, that doesn't mean that there aren't other devices available. This is the guidant neuronet, and you can see it's the same kind of concept. Basically, the catheter goes up into the artery, is advanced past the clot, the net is deployed, and then it ensnares the clot and sucks it back into the catheter. And this is a case of one of the patients who received the guidant neuronet. Again, this is an angiogram with a blood vessel, and you can see that there's a blockage here preventing flow. And once the catheter has passed and ensnared the clot and removed it, you see resolution and resumption of flow. You may have to take my word for this, but this is the same patient, and they had a CAT scan which doesn't show any stroke. Just like in coronary arteries, where you may have heard of angioplasty and stenting, the blood vessels in the brain can be filled with cholesterol as well. This is an MRI picture. These are the temporal lobes, and this is the brain stem. And what you can see here is this increased signal. That's a stroke. It corresponds to this area of narrowing in the basilar artery, which is what serves the brain stem. With angioplasty, which is a balloon that is deployed into the artery that pops this area open, you can see that the diameter of the vessel here is much larger than the diameter of the vessel there. It's a little more evident on this picture. You can see this is a picture of the carotid artery. This is the internal carotid artery, and it looks like someone's taken a bite out of this side. After, you can see these hatch marks kind of vaguely. That's a stent, and it's been deployed just to pop the artery open and to keep it open. So far we've been talking about dissolving and removing clot and restoring blood flow. But is there a different way to think about stroke? What about limiting the size of the infarct? Brain cooling has been shown to potentially limit the size of the infarct. In some research that was done here at Stanford by Dr. Meyer-Albers, what you can see, it's kind of a difficult slide to see, but basically this is in mice. At normal temperature, the mice had strokes as big as these white bars. But if you cooled them down, you could see that the size of the strokes in these 3 locations of the brain were almost half to a third of the size. So unfortunately, my little video clip didn't work. But another illustrious member of the Stanford Stroke Center, Dr. Christine Wyman, she has brought hypothermia therapy to Stanford. And this clip was about a Stanford law student whose heart stopped and resulted in decreased blood flow to the brain. And because of that, he went into a coma, and she treated him with a catheter that cooled the body down to limit any injury to the brain, and he was back at school. Some novel treatment trials that we're going to be participating in soon is a trial of low-level laser therapy directed at the stroke site. This laser therapy has been shown to limit the size of heart attacks in animals, and it also apparently has special effects in nerve tissue. It appears to exert its effect by increasing energy production in cells at the mitochondrial level, that powerhouse of the cell, if you remember from biology. What I think is great about the potential of this therapy is that, as you can see here in green, TPA works only in the first 3 hours or so of, after the onset of an acute stroke. And the Mercy device, the other therapy that's been FDA approved to treat acute stroke, works up to 8 hours. But if this laser therapy works, we might be able to treat patients up to 24 hours after their stroke. All it would entail is a little bit of head shaving and this funny TheraCap. and this gentleman, or one of us, with a laser directed to the brain. What you can see here is the animal data that supports this type of therapy. This is a control mouse brain, and this mouse didn't get the laser therapy, and you can see that they've had a stroke that has eaten up this part of the brain. If they've gotten the laser therapy, you can see that more of the brain is preserved, and that's the same thing that you see in a different section of the brain. Dr. Gary Steinberg, chair of neurosurgery and another co-founder of the Stanford Stroke Center, has been exploring stem cell transplantation for stroke treatment. And although that it's a very exciting treatment for stroke, it's not quite ready for prime time, but it's definitely a novel therapy that's almost underway. In conclusion, what I hope you take from this talk is to remember that twice as many women die of strokes than they do of breast cancer. Hypertension and high cholesterol are modifiable risk factors that can be treated. And remember, don't smoke, and time is brain. But what I fear is that instead of remembering these things, you're going to remember bat spit, brain cooling, and laser therapy. Thanks.
So now is time for questions. So does anyone have any questions? So the question is essentially if you've already taken hormone replacement therapy, what is your risk in regards to this, although you may have stopped at this point in time? Well, I don't know that I could give you an exact percentage. It is higher, but I think the key factor is that you've now stopped. So I'm trying to remember the exact number, but it's not coming to the top of my head. But it is increased. I think in the patients that received the hormone therapy, it was a comparison of like one in terms of the treatment was like 12 women who were on the placebo compared to 26 out of say 1,000 women. So it was an increased risk. It's not. I don't think it's anything to worry about. But I think the point is now that you've discontinued it. So just make sure that you're doing everything else in terms of modifying your other risk factors. The question is in regards to the timing of getting to the emergency room and sort of a quick fashion. Actually, the ambulance services are already sort of keyed into places that are stroke centers here in this area. So they know exactly where to take you, what physicians are available that would know how to give you the TPA or these clot-busting medications. So they're in tune with that. Sometimes we do get transfer patients from other ERs and advise over the phone, but they, in general, are aware of what hospitals or emergency rooms are stroke centers. So I guess the question is focusing in on CTs, which are an X-ray, and that exposes you to radiation versus MRI. Yes. MRI is a big magnet, so there's no radiation involved in that, but CT is an X-ray and there is radiation exposure. The reason why when you come into the emergency room, especially in the acute time frame, the clot-busting medication or TPA that we use, the trial that was originally done to assess whether that was a good medication, they used head CTs, non-contrast, no contrast was injected, head CTs. And that is actually a better method or a quick method that we can use to rule out that you've had a bleed in the head. Like Dr. Kumar was saying, in terms of eligibility for TPA, we need to first make sure that you don't have a bleed in your head. MRI is a fantastic tool. There are so many different special sequences that physicists and people brighter than myself have figured out. You can do special sequences where, like Dr. Kumar was showing, you can see the stroke in a very short time frame, within, say, 20 minutes. The problem with CT in terms of the ischemic stroke or the blocked blood vessel, it actually takes time for that to evolve on CT. We may not see that for hours later. So MRI can pick up that stroke in a much shorter time frame than the head CT does. The head CT sort of lags behind the MRI. So that's maybe why they saw it on the MRI instead of on the head CT when you came in. The question is whether or not mitral valve prolapse is a risk factor. The prolapse in of itself isn't really a risk factor. I mean, there are different degrees of prolapse. Sometimes people who do have prolapse are at risk of the arrhythmia of the atrial fibrillation at times. But the big concern sometimes with prolapse, or for whatever reason, is sometimes people who say go to the dentist or have valvular abnormalities and they get bacteria that get on the valve, that can flick off and go into the brain. But just having prolapse in and of itself doesn't put you at much higher risk or something. So the question is in regards to family history. Yes, family history of stroke puts you at higher risk, and many times that genetics may translate into having high cholesterol or diabetes, and those risk factors that contribute your risk factors for stroke. In regards to the first couple of slides that I showed with the aneurysms or the outpouching of those vessels, sometimes that can be genetic related or sort of have a family inheritance, although that may be rare. The question is, if you were taking a medication, it was thought that that medication caused the stroke, and you no longer take it, are you still at a risk of having stroke? Well, I would say anytime anyone does have a stroke, your risk is higher no matter what, whether it was from the medication or something else, high blood pressure or diabetes or cholesterol narrowing in your arteries in your neck. I guess one of the medical conditions I listed is if you've had a TIA or a stroke in the past, that does put you at risk in the future. So the question is, do men and women differ in regards to their presentation of the stroke symptoms? From what I've read in regards to this presentation is they can be different in regards that women sometimes present more with, say, dizziness or speech problems, but they certainly do present with weakness on one side of the body, just like men. And then the other one I think was speech problems. In regards to looking at in the various studies and separating the men out from the women, as they had more speech problems, dizziness, things like that. But again, they can present with weakness. And just to get back to, I guess, your question as well, is that, in terms of the clot-busting medications, you do have to have a certain number of symptoms, severe symptoms, for us to consider you for the clot buster. We wouldn't necessarily give you something as powerful if you just had some numbness or tingling on one side of the body. We would do it something, if you couldn't move one side of your body or you couldn't talk, things like that. The question is regards to if you're suspicious that someone's having a stroke, what should you do? I would say obviously the first thing is to call 911 right away, or if you have somebody and you're with the individual, you can have, if someone else is in the house, you can obviously have them call 911. I would not recommend driving someone in your car because sometimes stroke patients can decompensate and get very seriously ill quickly. And so the best thing is to have the paramedics come and help the patient. I don't know. And in regards to back in the presentation with the stroke symptoms, I did mention, and if you're trying to assess someone, or if you're not sure if they're having a stroke, you can ask them to say their name, ask them to try to smile for you and show your teeth. And the other thing is ask them to lift their arms up and see if they are able to do that on both sides. So the question is, he had, as I guess, read or saw something in regards to lying on the affected side. I mean, some people, again, I think it depends on the circumstance. Sometimes people say lay the patient down to augment blood flow. The only thing, the caveat that I say with that is sometimes people aren't swallowing or controlling their secretions well. And so they're at the risk of getting those saliva down into their lungs. So I would just make sure that they're in a safe location is the most important thing. They're not at a fall risk or something. They're not, standing up or something like that. I would get them to a seated position or laying down first and foremost. In regards to the side in which they're laying down, and again, I don't know if you have any comments in regards to that, but I'm not aware that that will necessarily do anything in the long term.
There are also some parts of the brain that, when they're affected, you're almost not aware of that part of your body, and so sometimes they may, inadvertently lay on that side because they don't recognize that that's a problem that they're having. So sometimes it could be just part and parcel of the stroke symptoms that they have.
I guess in the final conclusion, also if the patient has vomited, it's probably a good idea to get them on their side, to lay them on their side. But aside from that, I'm not aware of side-specific laying down. The question is, what causes ischemic events, and why are you more susceptible to strokes? Well, I guess referring back to one of the initial slides in regards to what causes ischemic strokes, a lot of times risk factors, like we mentioned, high cholesterol, diabetes, high blood pressure. Over time, you can get sort of narrowing of the blood vessels in the brain as well as the blood vessels in the neck. And so as blood passes over there, sometimes because it's narrowed and irregular there, clots can form and occlude that artery and cause decreased blood flow to the brain. And then in the other case I mentioned was because of the plaque buildup that you have, say, from high cholesterol and diabetes and these risk factors, little pieces can break off. Clots can form there and break off and go up into the brain and occlude a smaller blood vessel in the brain, as well as conditions in the heart, certain arrhythmias, you can form clots, and that can break up and go into the brain and occlude a vessel. In regards to the TIA, well, sometimes what happens is the clot actually breaks up on its own, and then the blood flow is restored, is sometimes what happens.